Good evening, everyone. I'm Bonnie Baker, Executive Director of the Canadian Lymphedema Framework. And on behalf of everyone here, I'm excited to welcome you to episode 3 of Pathways Live, Authors in Conversation. This special live stream series brings some of our magazine's most compelling articles off the page and into real-time conversation, sort of like a book club for lymphedema. Each episode features the author of a selected Pathways article. Before I introduce you to our host and our guest author for this evening's episode, I have just a couple of notes to share. Prior to joining us here this evening, you should have received a link for the digital access to the reading materials for this episode, including the article that we'll be discussing. In case you didn't receive the link, or if you need it again, we'll place the link for it in the live stream chat for you. We hope you have a good internet connection and a nice quiet place to enjoy the live stream, but know that if you should get disconnected for any reason, we will be recording the session and we'll get that link out to you in the days ahead. I'd like to take a moment now to acknowledge the generous support of our industry partners, whose sponsorship helps the CLF to deliver great programs like Pathways Live to you, the lymphedema community. So our sincere thanks to our diamond partner, Bauer Find, and our platinum partner, Juzo, and to Essity and Medi, Wear Ease, Lymphology Skincare, Sigvaris, and Eleanor. Now, without further ado, I'm pleased to introduce you to our host for the evening, Pathways Editor-in-Chief, Anna Kennedy. Anna is a CLF founding member and the editor of Pathways, which is the CLF's official publication. She spent 30 years in corporate senior management, working in the areas of training and communications for international companies like Thomas Cook and American Express. Her last business role was vice president with Indigo Chapters before she transitioned into the charitable sector in 2006. Anna served on the board of the International Lymphedema Framework from 2012 to 2020 and was the CLF's executive director from 2014 to 2019. She received Anna was awarded the Queen Elizabeth II Golden Jubilee Medal in 2002 for her leadership and her contribution to the lives of Canadians. She lives in Toronto, Canada, and she advocates for a healthy living and a positive attitude for living with lymphedema. Please join me in welcoming Anna Kennedy.
Hi, everybody. Nice to see
Hi,
everyone.
Anna.
Hey.
All right.
Can you hear me all right?
I hear you all right. Welcome.
Perfect.
Get an exciting guest. I'll let you introduce her and take it over.
It's great. I'm really pleased to introduce everyone to Beth Hoag. Beth Hoag is a physiotherapist and a certified lymphedema therapist whose practice has focused on cancer rehabilitation, including lymphedema and pelvic health, since 2008. She owns a cancer rehab practice in Ottawa, Ontario, and offers online educational and recovery programs through the cancer rehab space. Inspired by her mother's intentional approach to living with metastatic breast cancer, Beth's journey into cancer rehab was deeply rooted in finding personal balance and supporting others to step onto her personal power. Her education interests have shaped her comprehensive approach to cancer recovery. She holds a master's in physiotherapy, a Bachelor of Education, and a Bachelor of Arts. She also has extensive training in lymphedema therapy, pelvic health, orthopedics, needling, myofascial release, fitness programming, and mindfulness. And in addition to her clinical work, Beth sat on an international expert panel that guided clinical research on lymphedema risk reduction and early intervention strategies. She's the education chair for Breast Cancer Action Ottawa and serves as the advocacy representative for the oncology division of the Canadian Physiotherapy Association. Welcome, Beth.
Thank you. It's wonderful to be here. Can you hear me okay?
Yes.
Perfect.
It's so nice to finally, we've had lots of interactions by phone and email back when you started the article. Gee, that seems so long ago. Wasn't that
a
year ago, I think?
But yeah, I think well over a year ago now. Yeah, you're right.
And just when you thought you were done with this, you get an email saying, we're doing this series called Authors in Conversation. We'd like you to be part of it. So thank you, because it, as people might not know, there's a lot of work that goes into something like tonight, just getting prepared, writing scripts, and focusing on which questions and answers we think that people might be interested in. And thank you to everyone on the call who has submitted all their questions in advance. We've incorporated most of those into the script and into the Q&A, so I don't think you'll be disappointed, and we'll go from here. So you've, Beth Hoag reported in her article that axillary web syndrome, known as cording, is a common but often overlooked side effect that can have a significant impact on the quality of life. It's a common reason for people seeking cancer rehab physiotherapy treatment. So understanding the signs, symptoms, and treatment options is important for both patients and healthcare providers alike. That's why we chose that topic and Beth for tonight. But a little bit of fun stuff before we get into the serious stuff, just so we can connect with you on this call. In order for the audience to get to know you better, perhaps you can spend 2 minutes sharing what a typical day looks like in your clinic,
Right.
in your busy clinic.
Yeah, I know. I chuckled when I read this question. A typical day is, I'm not sure if there is a typical day, but so I think about a decade ago when I started my own practice, I took a bit of a different approach. I really wanted to create a safe, comfortable space for my clients, but also better balance for myself. I believe in practicing what I preach and the things that I talk about with my clients and out in the internet world. I really believe strongly in it and practice them myself. So my perhaps unorthodox way practice is I have a home-based practice now. So it's just me. I am the physio, but I am also the admin and the educator and all of those fun things in between. So I see clients 3.5 to 4 days a week, and I see one client an hour, which I'm sure for some clinicians listening might sound like a bit of a dream. But, I worked really hard to create that balance for myself and my clients. And then I save a day to a day and a half to do all the admin things that inevitably pile up and back up. So I'm not working evenings and weekends, which I absolutely was when I first started doing this on my own 10 years ago. It took some time to find that sweet spot, and the sweet spot shifts all the time. But I also take an hour for lunch, which I never used to do. It used to be 5-10 minutes, as a physio, if I was lucky. And my husband even commented on how much slower I eat meals now because I'm not scarfing it back, So I actually do enjoy and eat my meal and take my dog for a walk at lunch. And the end of the day is sort of all the catch up, the charting, the getting to emails galore, writing letters, all those admin things that maybe we don't think about physios doing, but they're there, and we all don't like paperwork, but that's the reality. Some days I really do a good job with the balance, and other days it's a bit of a hot mess, but that's life. That's the reality. And it's always a moving target. I guess that's sort of an average day for me work-wise.
And when you're not working, it sounds like you wear tons of hats, but what are 3 things you like to do when you're not working?
Yeah, when I have lots of interests. I joke that I won't have trouble when I retire. But I think my top 3, I do pottery. I've been doing it for quite a while and absolutely love it. I at a community studio and go in there a couple times a week. I am an absolute dog lover and have one of my own. And anything that keeps me active and being outdoors. I love being physically active. I feel better when I'm physically active. And if it's on the water, a bonus. In the summer, I'm a dragon boater. In the winter, I swim with a master's team, amongst other forms of exercise. And wintertime brings cross-country skiing for sure.
You're a little bit of an overachiever, I see here.
And I am toning it down as I get older. There's no doubt about it. Working hard to go down.
Thanks for taking the time to prepare and spend the evening with us tonight. So let's get right into axillary web syndrome. I know in your opening paragraph in the Pathways article, so I hope everyone had a chance to read that. I know it was sent as pre-reading, pre-book club type reading. You mentioned in that opening paragraph there's limited studies that have examined the impact, but it's quite common. So what is cording? Can you briefly explain what it is and why it appears for some and maybe not others?
Yeah. So what we know about cording is it's really a series of rope or string-like structures those cords can be quite thick and clumped together, or they can be a series of thin strands. And we'll have some pictures in a moment from the article. Actually, sure, we can do it right now. So the thin corner, you can see there's a couple thin cords on the left, and then the one on the right is a bit more of a thick cord. And this was actually the same client at a different period of her healing process, which is interesting. So they can appear in different ways. It can happen just in the armpit or the axilla, or it can also very commonly travel down the arm in a very common, clear line, if you will. So you'll see that it goes on the inside of the bicep, the upper arm, and then it can extend down. You can see in this picture on the left into the crease of the elbow, that cubital fossa, as one, or this picture has a couple of strings. And then it can even, I don't have pictures for it, but it can even keep on going down the forearm on the thumb side of the forearm, and can extend almost and into the base of the thumb as well. So that's more the classic pathway of it. We can less commonly, but it does happen. We can get cording in the trunk. And when in my clinical practice, when I've seen it, it often runs sort of the front below the breast, if you will. And I have seen it go down the side as well. But again, it can be thick or series of small strands. So that's really what it looks like, and where it can occur. In terms of the symptoms, often the data, we need more data. I'll say that probably a million times throughout this talk tonight. But my answers are coming from the best data that we have, and then my clinical experience, which is kind of the nice thing about this chat tonight, is we can add that flavor in. And what I often see clinically is there's a sudden onset of pain and or tenderness anywhere along that pathway, but often the whole arm. The data really shows tenderness, aching, and comments about tightness are really common as symptoms. We also see a loss of movement of the shoulder, which just kind of doesn't make sense. There's nothing they've done or anything that's happened that comes on. And sometimes we do see mild cases of swelling. And I like to highlight this because some of these symptoms, for those of you who have experience with lymphedema, there's sort of some overlap here, right? There's this heaviness, aching, new onset of really mild swelling, or a feeling of fullness and tightness with no real visible swelling. So, we'll talk about it later, but coming up with that differential diagnosis about what's going on is really important, that we know that these things can coexist. And then when it can happen, the data says sort of 2 to 8 weeks post-surgery. And 3 weeks, I find, is really that sweet spot where a lot of people start to, if it's coming on, notice these symptoms, is about 3 weeks post-surgery. And that's absolutely what I see clinically. I am going to add, and I didn't read anything in the literature that I reported on in my article, I absolutely see this come on for the first time after radiation as well, which makes sense. And we'll talk about kind of what we think is going on and the whys. But it's around that sort of 3 to 5 week post-radiation. Absolutely, I've seen it be a starting point for some people.
And is it unusual to have it 7, 8, 9 years after surgery? Is that a little more unusual?
I would say yes, that is unusual. We do know that, let me back that up. It's unusual. So this is where having someone who has experience in this, who is trained in coming up with diagnoses, and a physiotherapist is one of those people, or seeing your physician is really important, because that's not common. So if that's happening, and it can, but it's not a common time, we need to rule out other reasons why that could be happening, which is really important. We do know that it can come and go. So we know that these symptoms can go away or really ease, and then they can come back. And there is a small subset of people that do have this reoccurring cording. And I've got a few in my caseload right now. And we don't know why. We don't know why that happens, but that is a pattern that we do see as well.
So let me back up a bit when you said there's differential diagnosis. That's important, and why it's so important to see someone with experience in this. You need a proper assessment of the cording, because, as you say, it masks other things, and you need to rule out other things. What are some of those other things that might present itself or might be confused with presentation of cording?
I think even before I answer that is to qualify when this is really important. If you're 3 to 5 weeks post-surgery, this is a pretty typical time for this to happen, right? So that is not a time that I would be be super concerned about something else as a clinician going on, or if it was after radiation, that makes complete sense to me. If though it's someone who is 8 months out, for example, that doesn't fit a typical clinical picture. So then we need to be looking at, could this be lymphedema coming on? Is this something, with or without, the presence of visible corning, but they have these symptoms, lymphedema? Could there be some other musculoskeletal injury going on in the shoulder or the neck? And then the one thing that we never like to talk about, but we need to talk about, if someone has a history of cancer, we need to be making sure that something isn't happening with the cancer itself. And that is where going back and seeing your oncologist or someone in your medical team is really important.
Yeah. So you talked a little bit about the overlap between lymphedema and cording. When we start talking about treatment then, when would MLD and compression help? Only when you see that overlap, not for cording on its own?
Yeah, so there's nothing in the data that definitively answers this question. My extrapolation from using logic and understanding of the science behind this, when you have some fullness or swelling present, or even those stage 0 lymphedema symptoms, this heaviness, this aching, that to me is an indication. Then yes, I think putting MLD and compression into the mix is a reasonable option. That has to be, you have to clinically reason that through, but that is a time when I, in practice, if I'm seeing any of those symptoms, I will include that in the treatment plan without a doubt. But to answer the other half of your question, in and of itself, if there's no evidence of swelling, we don't have the data to say yes or no. I can tell you clinically, I don't use it. Is that the right or the wrong answer? I don't know. But from a logic perspective, that's how I approach it with the science that we have to date and what I've seen in practice. So
why don't you share with our participants? So someone presents with cording. What is your first line of action? What's your treatment protocol? What types of things do you use?
Yeah.
There must be a variety of tools in your toolbox, yes?
Big time. And I think the first thing is a good assessment. As a clinician, whether you're seeing a physiotherapist, a massage therapist, whoever your healthcare provider is for this particular thing, an absolute careful assessment should be the first piece. And we've already talked about some of those, ruling out other reasons why that can happen, but also looking at, for this individual, everyone's a little bit different. And even though I've described that common pathway, not everybody is the same. Mm-hmm. So trying to figure out, I often talk about these tether points with cording. And I often find clinically that some sort of scar adhesions in the axilla or the armpit from the surgery and or radiation, that there's often some tethering going on. So figuring out where that line of tether is coming from, so we can really get at part of the root source of the cording. So once we've got that good assessment, for me as a physio, it always starts with education. I believe so strongly that it's your body and that it's really important that you understand what's going on in your body and why. So beyond the education, and talking about the things we should cautious of and shouldn't be cautious. Depends on if you have signs of lymphedema. We need to have some conversations around that as well, about how hard do you push with exercises. There's a huge education component to this. There's always going to be hands-on in my practice with cording. When I say myofascial release or myofascial techniques, that's a very large term. It depends on your clinic. Each clinician is going to have a different toolbox of myofascial techniques. One is not more right or wrong than the other, with the exception, I would say, that we don't want to be aggressive. We don't want to be so hard that we cause more inflammation, because we know that inflammation is a part of cording. So there will be hands-on myofascial techniques. I'm almost always working down into the ribs with these folks, because I often find that there is some tethering down into the actual ribs themselves. So again, that's part of my assessment and treating appropriately. And then always giving exercises for people to do at home, because what we do in clinic is a big piece of the puzzle, but then it's a partnership. So sending people home with things to maintain and further progress their situation is really, really important.
That's sort of their homework in between
The
visits.
homework, yeah. I do usually use that term.
Yeah, and there'd be several, again, it's going to be different for patient to patient, but I would say it's a series of a series of treatment sessions post the assessment time period, right?
Yeah, for sure. And I think one question that might come up is sometimes when we're doing the manual release or fascial work around the cording, we can feel and see and hear snaps. Not always, but sometimes we feel those snaps. And I always warn clients, if you feel that, don't panic. I find that when we do get snaps, it's an amazing treatment response. People have significantly less pain, more mobility, sometimes a little more swelling if they have swelling present, but great gains are made with that. Now, I'm not saying we're going for the snap, but that can occur, and we don't really know what's happening. And that, when I was writing this article, looking, and there really were there were a few explanations, but they were theories, right? We just don't really know what's happening. There's theories about, are we breaking the scar tissue? Are we releasing the cord? We don't really know what's happening, but what I can tell you is things get better. Snap or no snap, but I figured that question is going to come up. So just
and is it truly a snap, like a snap, crackle, pop?
Oh yeah,
like
I'll never forget the first time I experienced it with a client. I kind of went, oh, and her eyes just popped and we looked at each other and went, oh shoot. But yeah, it can be. It is a snap, a crack, a snap, crackle, pop. It is an audible often sound, and they feel it. Too.
And then they feel the relief. They feel the relief after that.
After we've done, usually not in that moment, but yeah, once they sit up off the table, and it's like, wow.
Wow.
It's really quite interesting.
That's very, very cool. Does it completely disappear? Can it completely disappear then, the cording, or is there always sort of a low level hint of it? Or again, it
varies. Yeah. Some people, yes, it completely can go away. And maybe just to back or pause for a moment in answering this, that some people, a lot of people, it spontaneously does go away. And that's one thing we haven't talked about yet tonight, is that there's some argument to say, well, do nothing, because it often goes away in 3 months. But we do have some data showing that if we get some help in the door in the way of physiotherapy or other healthcare providers who do hands-on work, is that we can get you better faster and get you feeling better faster and improve your quality of life faster. So keep that in mind, that not everybody needs to see somebody like me. But getting back to your question, some people it goes away entirely. Many people, I would say almost if not everybody that comes to see me, they will get improvements. Absolutely. Better mobility, less pain, all of those symptoms, but they might always see a cord. That cord might not pop out as much. It might not travel as far down the arm or the chest, but there might always be a visible cord. So the goal isn't to get rid of the visible cord, although I know people would like to, but realistically, we often can't. It's more to decrease the symptoms, improve mobility, and improve your function. So it's not at the front of your mind all the time.
Yeah, I see some other some comments coming in, and other therapists are saying, yes, you and the therapist can definitely hear a snap. That's amazing. I had no idea. Do you sometimes use, this was a question from someone in the US, so they're just curious whether in Canada, you and other people use low-level laser therapy for...
Yeah, good question. I don't myself, but low-level laser is used in Canada. The studies, and I reviewed some studies prior because I knew that question was coming in, and the data is really limited right now. And so there's some suggestion that low-level laser, in addition to physiotherapy, but not in and of itself with no other intervention, it can be helpful. So yes, it is used. I don't use it in my practice and still get really great results, but it is being used in conjunction.
And does regular massage therapy, now, I'm not talking about, a certified therapist for lymphedema therapy, but just regular massage, does that help at all to ease some of the symptoms?
Yes. That's a trickier question to answer, because if you're talking about someone who doesn't have any awareness of cording, I'm not saying a massage therapist can't work this. They absolutely can, right? I work with lots of massage therapists, and we share clients and work together and get great results. So yes, an RMT, a registered massage therapist, absolutely can do this work, and they do this work as well. The studies that I talked about in my article, they're based on physiotherapy, which is why I commented on physiotherapy in the article, right? But absolutely, clinically and practically, for sure, massage therapists. If they don't have the training, that's a little bit different, right? Because they're often, they don't know what they're looking at. They don't know what they're treating. They're not, So I'm not saying it's wrong. And I appreciate that not everybody can get to a hands-on therapist that has some experience. But sometimes even just working the muscles around the area can help, but you're not going to get you're not going to have as big of a bang for your buck, so to speak, with someone who doesn't have the experience and knows where to go.
Yeah. Someone had ahead of time and also tonight, right on the call, saying, is there a window period or a certain period of time that you can begin myofascial release post-surgery? Is there a time period that you have to stay away from, or as soon as you see it present itself, you can start?
Yeah, absolutely. Again, if we think about when this most commonly presents, is around that 3-week mark post radiation, post surgery. That's usually the time frame, if we just understand healing timelines, where our body is starting to ease out of that inflammatory phase of healing. The scar tissue is starting to gain some strength. We can get in there and start doing gentle. I'm not going to be aggressive with somebody 3 weeks post surgery like I would 8 weeks. But yeah, we can start doing gentle myofascial work, gentle stretching. Absolutely. Again, we as clinicians, I'm directing this more to the clinicians who are listening in, is we have to use our clinical reasoning here in terms of understanding healing timelines. But absolutely, we can start this. It's unlikely you're going to see cording on day 1 post-surgery or day 1 post-radiation. They usually take a bit of time to kick in because we know that there's an inflammatory response. We're quite sure there is probably a role of scar tissue in this. And that's a question we haven't talked about yet, is there are some studies showing that we're pretty sure that there is a thrombosis within the lymphatic vessels and sometimes even the adjacent blood vessels or veins. So that takes a little bit of time to happen. That doesn't happen immediately post-surgery, immediately post-radiation.
Mm-hmm. And are there things that put a person at more risk? So patients might be concerned after surgery, repetitive overhead activities like swimming laps or lifting heavy things, or what could contribute to either the start or re-emergence of cording?
Yeah. So the risk factors that we do know that we do have some science on is the more lymph nodes you have removed, the greater the risk of this developing. And so we're seeing more sentinel node biopsies, thankfully, being done as opposed to full axillary clearances now. So we're seeing the number of people getting cording decreasing, but more nodes removed is a greater risk. We know that thinner individuals, and we don't really know why, but clinically, I absolutely see this, is that my thinner clients are often the ones who get this over someone who just isn't as thin. Those are the two we know very much so. Everything else, we're not as sure. There's been different theories and different proposals about, they say younger age, but we also know that younger age, they tend to be thinner as a group, right? So we think that might be more correlation, not cause. Those are the things we know for sure. And those absolutely I see in practice. Absolutely. In terms of, and this is a question I get, is, any activity that might have bring it on. We don't have any data to back that up right now. Clinically, do I see that? I can't say I do. I can't say it is usually related to anything in particular. Maybe the 1 or 2 times clinically, caveat I can say is if they are early stage healing and they do too much of something too soon, let's say, I don't know, clean their whole house on week 2 post-surgery, that's going to increase your inflammation. Your body's not ready for that. It's still healing from surgery or radiation. So maybe that might contribute. And again, we're just using a bit of clinical reasoning here, but I wouldn't say there's any one thing that I would say don't do because of cording risk. It would be, you need to be gradually get back into things because you're healing
for lots of things.
You got it. Exactly. Yeah.
A question came in, how about treatment tips for cording through breast tissue, which is very difficult to stretch in this area?
Yeah. So cording, I'm not sure through breast tissue, but often it can sort of sink under the breast tissue. I've certainly seen clinically, and there's absolutely fascial work that you can do to the breast itself or by way of the ribs. So it's a little tricky for me to answer specific treatment questions, but I would say going back to that assessment about feeling for the line of pull of that cord, is it going under the breast? Is it going into the breast tissue? Is it going down into the rib? And you can access points either on the other side of the breast, or even I made this action because if you think about the breast a little bit like a balloon, you can gather the breast and fascially stretch the breast in different directions and get those tissues underneath if that's where you feel the cording is anchoring down.
But it must be a little more difficult. I mean, under your arm, there's a lot less tissue and less, density of tissue than a breast. So it must be more difficult to diagnose or to see, but the patient themselves would obviously feel the pain and feel that tightness, right? Regardless of whether it's under the arm or in the breast.
Yes, they would feel it for sure. And of course, my clinical brain is going to, I need more information about the assessment, right? To me, I need more information to really know what's causing that. But yeah, definitely there's more breast tissue, but if you've got the experience and you've been working with your hands as a clinician, you get to feel lines of pull. You can feel that things are traveling down deep superficially. You get those skills the more you work on it within this population. So it's very doable. Yeah.
Yeah. Did we say we'd go do later, or did we cover? We talked about why it's so important for someone with experience to do the assessment. So what are some of the other things that could it possibly be? I mean, a thrombosis, you said a DVT, a few other things. What else should they be looking for to be ruled out?
Yeah, I think we mostly did cover that already. Yeah, so I mean, if there's swelling or pain, we want to rule out a DVT for sure. And that's clearly, me as a physio or a massage therapist is sending them back to their physician. That's not something I diagnose, obviously. But ruling in or out lymphedema, which can coexist, as we've talked about. If we've got a concern, if the story doesn't fit the typical sort of 3 to 8 weeks post-surgery, post-radiation, I might be considering sending them back if something just doesn't add up, to make sure there's nothing else medically going on.
Right.
And then the other time, often, which we haven't really talked about, is just that the scar tissue in the axilla, but also the muscle tightment, any fascial restrictions that can happen with these post-surgery, post-radiations. I'm amazed, how much that can contribute to it. But those are really the most common things that we just want to be ruling out. The other one that I haven't talked about, and doesn't present exactly the same, but if it's someone who's had chemotherapy, through IV in the arm, we can get sclerosis, so a tightening of the vein that treatment has gone through. And that sometimes, if it's been in the armpit or up near the thumb, that can have somewhat of a similar presentation. It's not exactly the same, but absolutely that might be something to be thinking about as a clinician too, and asking, have you had chemo directly into the arm by IV? That could be something else.
I want to sort of skip back a little bit, but the same person asking about the breast treatment tips. Her comment is there's definitely cording, definitely in the breast tissue, disfiguring the breast, but not under tissue. and using a line of pull not working. I don't know if you have any other, you've seen that, what other tips?
I think when we're starting to get really specific with patient questions, I am happy to answer those offline. If you want to email me,
that's a great idea.
I think this needs to be a bit more of a conversation back and forth.
Yeah.
But I am more than happy to, Linda, if you want to email me, I am more than happy to have that chat with you offline.
Right. Yeah. And we'll at the end of the session have some reference material that Beth's provided, some resource material. We'll direct you to her blog. She's got a wonderful blog, and we'll go from there. So I'm just monitoring the questions coming in. I think we've answered most of them, but I have a few more questions. So what can people who experience cording do to relieve symptoms at home, to supplement any visits to the physiotherapist, or before they see a physiotherapist? What can they be doing when they suddenly see that already?
Yeah, absolutely. So again, I think as someone who's experiencing these symptoms, I'm going to go back to what I've already said, is if you're feeling, yes, this is within that timeline that's common that we've talked about, I'd carry on with what I'm about to talk about. If you're 8 months out, if you're farther out, that's not, more than 8 weeks out post radiation or post surgery, I probably would be touching base with your family, with your oncologist or your oncology team, just to be safe and say, hey, these symptoms are showing up. Is there, just in case there's something else they want to check? I think that's important to be thorough. Mm-hmm. Assuming that is not the case, then there's lots of things you can do. Even if you don't have access to somebody like me in your area, there are some really basic gliding techniques that we can use that for some people it's enough. And I've got some great YouTube videos on my YouTube channel, so I won't teach you those in the chat tonight. But there's some really basic sort of gliding techniques where we're putting things on a bit of a pull and then coming in and out of those pulls. There's also, you can do just sort of, if you're feeling tight in your armpit and chest, you can do some basic stretches to those muscles to start to alleviate that a little bit. I don't typically recommend, people ask me a lot, should I get in there and really go at the cording? I don't usually recommend that until you've seen somebody, just so you don't hurt yourself. But yeah, I think in general, I wouldn't recommend that as a starting point, but it's amazing how just getting some of these simple gliding techniques and stretching, it can really make a big difference. And if it resolves, great, you don't need to go see somebody like me. Mm-hmm. And if it doesn't resolve, or if it gets better, but it comes back, or it's not quite enough, then come on in and we'll start to get a little more targeted and figure out exactly where your cording is sort of tethering in and where we need to go.
So the physiotherapists on the call will know what it is. I'm not a physiotherapist, and I see there's a few patients on the call. What is a glide? Like, is it a tool? Like a?
Oh, no, it's literally, it's a movement. Okay. So, so we talk about, stretches. I think we all know you kind of get in there and you hold something, right? And that's getting at muscle and fascia, that connective tissue. But when we're talking about gliding, I often describe it, if you imagine a piece of floss in a straw, and there's a couple pieces of gum in that straw. So if you're trying to move that floss back and forth, it's getting caught on the gum every once in a while. If we pull on both ends, that's not going to change anything to that snagging. But if we go a little bit back and forth, meaning we go into some stretching, so think about that line is getting longer and then coming back out of it, then we're starting to slide and glide along those structures, the lymph vessels, the vasculature that's snagging a little bit in there. And then that can start to loosen it up, or maybe loosen it up isn't the right word, free it up. So it's freer to move without that pain or restriction.
Yeah.
Does that answer that question? That's a good question.
Yeah. I figure it wasn't gliding on the ice in Ottawa. It was something else.
Too soon anyways.
You don't have ice there yet? You've got some snow.
We do have some. It was it's a bit icy tonight.
Where can our I'm just monitoring the questions. I don't think there's other ones that people have submitted while we're chatting. Where can our listeners go to read and educate themselves more about cording?
Mm-hmm. So I think some of the I can guide people to the articles that I've written. Obviously, we have the Great Pathways article itself, so that's a great starting point, and that really gives some really good, the best evidence that we have at the moment. I also have an article on a blog on my website, which is a bit simpler in terms of how it's written, probably more helpful for those experiencing cording rather than clinicians who treat cording, but nonetheless is still a great starting point. And as well, I have a few YouTube videos that go through some of those gliding techniques. Oh, there you go. There's some well done, whoever put that up. So that goes through some of those and explains a little bit what cording is and how you can start to work on it yourself. So there's some basic exercises. And then the next video is, okay, if these are getting easy, here's the next thing that you can try working on. And if that's not enough, then find your way to somebody who can treat you.
Thank you, Grace.
Thanks, Grace. Well
behind the scenes. Those are amazing. You've done a great job. It is just you're not only a great therapist, but a great communicator and great trainer. Is it common to get cording more than one time?
Absolutely.
Yeah.
I would say it's a small subset of the people who get cording, but it absolutely happens. Absolutely. I can't tell you why. I can tell you that I have very commonly seen people get cording after surgery. We ease off those symptoms together because we're working as a team, and they carry on, and then they kind of sneak back up after radiation. That makes sense to me. That one does make sense because there's inflammation. There's more scarring happening after radiation.
Right.
That makes sense. But beyond that point, I can't explain it, why we get these waxing and wanings. I do often find the people who have the coming and going in my practice often are the same people who have coexisting lymphedema. Oh. And that does make a little bit more sense to me because we know that lymphedema does go through these periods of mild flare-ups. And so I would say, and that's just an observation that I've seen. If someone's listening who does research, please let's talk. I'd love someone to research that. But I have absolutely seen that pattern clinically in my practice.
And if you've got lymphedema at the same time, is it painful to wear compression when you've got cording?
That's a good question. So usually no. I will say that occasionally in the early stages of cording, I absolutely have had clients who are hyper sensitive and having a lot of pain in this area of the arm. And we know that, or we're pretty sure, I think we know, that one of the nerves that goes down the arm called the median nerve can get tethered into this cord along with those other structures. Those are the people I think that are getting this hyper amount of pain in here. So in the early stages, before we've really worked and improved this, sometimes they don't tolerate compression at the beginning. So we have to get creative and manage the lymphedema in other ways until we ease off that pain from the nerve being caught up in the cording. And then no, it shouldn't be painful to wear it. You know, compression really should never be painful to wear. So if it is, you gotta figure something out.
Yeah, if anything, comforting and feeling more contained.
Exactly.
Has cording ever been captured in digital imagery?
Ooh, that's a good question. I don't know the answer to that.
That would be cool if it is.
Yeah, it's me geeking out over here. I'm thinking that'd be amazing. They definitely have done studies. Sorry, I can't think of the term right now, but after people have died, dissecting and looking at what the cording structures are. And that's where we've become fairly confident that there's thrombosis going on, scar tissue. So we know that, but in a live person, not to my knowledge, but that would be pretty cool to be able to really see it.
Well, that would be. If there's one thing you want our listeners to take away from our discussion tonight, what do you think that should be?
Oh, that's a good question. I would say to those who are living with cording, your symptoms absolutely can improve, but you might not fully be able to get rid of the visible cord. I think that's a common misconception I see in my practice. And to those who are clinicians, if you're newer to working with this population, be gentle with these people. There are different techniques for myofascial release that are quite aggressive, and it makes me nervous and cringe a little bit because they're really increasing inflammation in that time. So be gentle. I would say look to the base of the cords or the start of this whole problem, and make sure you rule out other causes if they're not fitting into that typical presentation of sort of 3 to 8 weeks post-surgery or radiation.
Mm-hmm. Yeah. Well, you've given us lots of things to think about and lots of ideas. And as we had said earlier, both Bonnie and Grace have committed to sending something out after all of our events. This is now our third one, with more resources, more links to the blog that Beth does, which is a wonderful one. I think that's how you came to I mean, it's not that we didn't know of you in the past, but I think that's how you came to the attention of the editorial board, seeing your commitment to the training and the videos, etc., for cording, and thought, gee, I don't think we had covered it before. We might have, like 10 years ago, many issues ago. We're now actually, Bonnie, Grace, and I are putting the final touches tonight. I think deadline's tomorrow, on our 57th issue. So,
Wow.
so I think it might have been 20 issues ago that we did a small article on cording, but we knew it was time to go in depth, and that no one could cover it as well and as comprehensively as you could. So thank you again very much. One thing that I found, I think, on your website a year ago when we were looking at, when we were corresponding about the article for Pathways, is when I came across your little poem, and it was right around Christmas time. I think it was also a fall issue, and so I thought it was just appropriate. And here we are, almost again, getting close to Christmas. So with your permission, we've already chatted about this. I think it's just so amazing, and I would love for us to run it. If it doesn't run, we will send you the link regardless to everybody on the team. But why don't we run that, and then I'll say my final goodbyes. Grace, are you able to run it, do you think?
We're going to give it a try. Give us just a moment here.
And otherwise, I have the script in front of me, but Beth probably does too. She could always just...
Oh, I have to pull it up, but I sure can if you want me to read it live. Oh, are we getting there?
Oh.
Here we go.
It was the night before Christmas, and all through the land, people were dreaming of a cancer-free plan. The treatments got better, and more people survived, but side effects of those treatments, they just couldn't hide. There was brain fog and bone pain and crushing fatigue. There was stiffness and soreness that was out of her league. It was surgery, chemo, and radiation they gave, and hormone therapy and immunotherapy was the ongoing wave. They all helped her to live, but they left in her wake an experience of physical and emotional heartache. It's normal. Ignore it. There's nothing you can do. This was the advice from all whom she knew. Be grateful you're alive. It could always be worse, is what she told herself, but it just sounded too terse. When out with a friend, she learned through a chat that there was much she could do to deal with all that. Away to the internet, she flew like a flash, whipped open her laptop and typed with a dash. The info in front of her made her jaw drop. This was the moment the suffering could stop. When what to her wondering eyes could appear but the term cancer rehab that was crystal clear. With a long, gentle sigh and a teardrop or two, she knew in a moment this was the missing clue. Knowledge is power, and take back control. Move more and sit less and suffer no more. There are tools for your tool belt, so many, you see. You just need to learn which ones for you are the key. These tools, they are yours to use whenever you choose. You just may need some guidance to find the right ones for you. And then, with a flitter of hope and surprise, she began typing an email to this physio as she opened her eyes. Today is the day. I take back control, and I'm done letting side effects all take their toll. Today, I choose to sit in my driver's seat and gain tools from my tool belt for my self-management sheet. I know cancer rehab can't make it all go away, but there's so much I can do to manage my day. And the best part of all is that it's my choice to take, to invest in myself, as there's so much at stake. So pick up the phone, type an email or DM. This is the way to get that helping cancer rehab hand. To thrive, not just survive, is the choice that I yell. Now that you know, cancer rehab can help.
I loved it. It was great.
I still get choked up even when I hear it.
I do too.
It's totally from the heart. I think, Anna, you and I talked about this earlier, is that was such a spontaneous moment of creativity when I wrote that. And it just sums up from my inner gut, soul, and heart about how I feel working with this population. And I think, there's so much loss of control when you're going through cancer treatment and beyond. And there's so much control gaining that can happen by working with someone like myself or in another discipline. So there's a lot we can do to help. We can't make it all go away, but there's a lot we can do.
Well, you've got the training, you're very educated, you got the experience, but what came through in that article or in that video is your heart and how you feel about your patients. So thank you so much for being that type of a therapist. And I'm sure many people watching it would have been touched as well. So we're nearing the end here. I don't see any other questions come in. We usually try to keep it to an hour or a little less. I know people are busy. I know we've got people from across Canada, also from the US and from other countries that had registered for tonight. Not all of them are online. Many of them wait for the link because of time changes, etc. I think we had 30, 40 countries, something like that. Which is absolutely amazing. And I know some of the American ones. I'm actually in the States right now myself, and I know it's 2 days before Thanksgiving, so everything is a flurry here, even though we've had our Thanksgiving back in October. But I know some people probably didn't attend simply because of that. So thank you very, very much. Thanks to Bonnie and Grace. They're backstage, as we call it, making sure all of this happens and all the right visuals go up at the right time, even though I changed the script once or twice. And I had a panic attack just 10 minutes before the start because my camera and my mic wasn't working, but it's all good. We figured it out. So thanks again. Bonnie, is there anything you needed to finish with or tell the audience on?
This was wonderful. Thank you so much, Beth and Anna, for putting this together for us, and to our viewers joining us. Thanks for joining us for this edition of Pathways Live. We're so happy that you could be with us today, and I hope that you found this insightful and meaningful. I certainly did, and your poem definitely choked me up as well. I'm glad I could take a moment before I had to come on screen. That was very touching. So again, we want to thank Anna and Beth for this wonderful discussion. And I'd also like to just take a moment to introduce you to Grace. I'm going to sneak her on screen and surprise her.
Yay!
Grace does an awful lot of work for us, all the communications with everyone to make sure everyone has all the links they need and makes the studio look great for us and puts all those things up. So I want to just thank her for all of her hard work on this. She's our communications and marketing manager. Also, I would be remiss if I did not also one more time just thank our sponsors. It really is the support of our industry partners who make these things possible for us. So again, Bauerfeind, Juzo, Essity, Medi, Waries, Sigvaris, Lymphology, Skincare, and LNR, we thank you for your generous support. We're so excited for our Pathways Live series, and we're just getting started. We're already busy planning our next episode, which will probably be in January. So stay tuned for updates and announcements in your inbox very soon. Grace will follow up with you in a day or two once we finalize the video, and also give you the links to all the great resources that were mentioned this evening. And as soon as we know what our next live stream will be for Pathways Live, we'll definitely share that with you too.
Great.
As Anna mentioned, she and her editorial board are busy putting the final touches on the winter issue. So if you are a Pathways subscriber, watch for that in your mailbox before the holidays. And if you're not a subscriber, well, we'll just send you a reminder about subscribing to Pathways. It's a wonderful publication. So happy holidays to everyone. We probably won't see you on Pathways Live again until the new year. And in the meantime, we'd love to stay connected. So if you have any questions, feedback, ideas for future sessions, please don't hesitate to reach out. We'll definitely share links with you for signing up for our e-newsletter, which is free, and joining us on all of our social media channels.
Yeah, and for people that were not able to come to the conference, which was fabulous, thanks to Bonnie and Grace for all the time and effort they put into a fabulous conference in Niagara Falls. But we have an extensive conference review in this next issue of Pathways. With great photos and little clips of what some of the key topics and the aha moments were. So stay tuned for that.
Looking forward to that. Thanks,
Good.
everyone, for joining us this evening. Thanks once again, Beth and Anna. Hope everyone has a wonderful holiday season, and we'll see you all again very soon.
Take care.
Great.
Good night.
Bye.
Bye.